Hello, my name is David Beukelman from the University of Nebraska-Lincoln and Medical Center. And today I'm joined by Susan Fager. And Susan, by way of introduction, tell me a little bit about your role in the AAC field.
Yeah, certainly. I'm the Assistant Director of our Communication Center at the Institute for Rehabilitation Science and Engineering at Madonna. I've worked in the AAC field for over 10 years. We serve individuals with a wide range of disabilities. But I primarily focus on adults with acquired and degenerative conditions in AAC.
And you also have a research role.
Yes. We do research at the Institute. We focus on new and emerging assistive technologies with adults with severe impairments.
This webcast that we're going to present today comes out of several years of work that we've been doing trying to serve people with very minimal movement and trying to support their communication. In this webcast, we will be discussing several different types of people with different medical conditions. This was a presentation that we did at the RESNA, or the Rehabilitation Engineering Society of North America, in 2009, as well as on the World Congress for Disability. The webcast is sponsored by the Rehabilitation Engineering and Research Center in Communication Enhancement. We call it the AAC-RERC for short. And we would like to thank them for their support. And we'd especially like to thank Olinda and Merle and John. You will meet them in videos in the film today. And they're doing more than just demonstrating the equipment for us. They actually work with us closely. And they give us their opinions about what they think about developing technology. And so they are very much a part of our effort. We also would like to thank Tom Jacobs of Invotech, who does a lot of our technical development work and, of course, contributes in a lot of other ways with his ideas as well. And then Laura Ball, who used to be here in Nebraska and is now working at East Carolina University. Laura was very active in the ALS area, and you'll be meeting more of her work later on. We'd also like to thank Amy Nordness, who now works with us in the ALS area. Finally, we'd like to thank Vicki Philippi from the Education Department at Madonna Rehabilitation Hospital, who helped us prepare this webcast. The presentation, will come in three different parts. The first one will be to talk about people who have minimal movement as a result of brainstem stroke, and they present a unique challenge that we'd like to talk about. Our work here is part of a project called the New Interface Project, which is part of the AAC-RERC. The goal of this project is to develop new AAC interfaces for people who present interesting challenges. We'd like to comment at the beginning that we're going to talk about some technology today, but truthfully, there are many other types of technology and technology that's quite similar to some of it that's produced by other companies. We'd like to refer you to Tech Connect, which is a website and a resource that is on this same AAC-RERC website for extensive information about the technology in the AAC field. And so let's begin today with people with four different etiologies. And Susan, you do a lot of work with these individuals. You want to kind of talk about the challenges that you face with them?
So let's talk about some of the challenges that a clinician faces with working with individuals with minimal movement capabilities. First off, a lot of them are medically unstable, and so it really changes your intervention in that you often have to limit the periods of time that you work with them. You have to work around the medical care providers because they're so medically fragile. They're very fatigued. Their endurance is low. Because their movements are so limited, it's difficult to find technology that fits what movement abilities they have. Positioning is an issue. A lot of them are in bed and can't tolerate sitting upright or aren't able to get up in a wheelchair yet. And also just the technology training and the ongoing support these individuals need, because typically the recovery is a slow process, or if they're in a degenerative condition, They might be in a wide range of settings, and so training is quite extensive.
Don't you also have a unique situation with someone has a medical issue like this, that as you're trying to serve them, you really have to maintain day-to-day communication because
Yes.
they need to communicate about their medical condition.
Right, and also the change in staff and caregivers that they have in a day-to-day situation in a medical facility really requires that ongoing communication.
Today, as we talk about these different areas, we're going to be talking a certain amount about clinical decision making. We'd like to call your attention to a book that was recently published, and it deals with a chapter in the areas of AEC and intensive care, brainstem impairment, spinal cord injury, as I page through it, traumatic brain injury, ALS, degenerative diseases, aphasia, and so on. And so what we did is we invited clinical experts in AEC from across the nation to get together with colleagues who were also very expert in that area and present a chapter on the clinical decision-making process for these individuals, and would encourage you to take a look at it if you're someone who currently serves people with acquired chronic medical conditions, or someone who plans to potentially in the future. And so what we're going to do with this presentation is we're going to kind of talk about intervention phases. That's how the book is organized. So why don't you start with the initial assessment for these people?
Yeah, so some of the initial things that a clinician needs to consider in working with an individual with brainstem impairment is first establishing a yes-no response mode. It's very important for these individuals to be able to communicate their basic needs, and one of the earliest signals we often try to find is a way for the person to signal a yes-no response. Additionally, a nurse call system is essential for an individual because they are so medically unstable. The fact that they might have some emergent medical needs they need to communicate to a nurse, finding a way for them to work a call system is essential. Some of these individuals aren't able to access a traditional call system or even an adaptive call system. At our facility, as an example, in these situations, we have to establish a 15-minute checking system where nursing is required to come in and check on that person every 15 minutes to make sure that they're okay and that their needs are being met until they can have a reliable and consistent way to access a call system. So your initial assessment really focuses on those basic areas. And then early in recovery, we find typically that individuals are communicating, when they're able to communicate, they're doing it in a low-tech or a no-tech means. And some examples of this are eye gaze systems. So early in recovery, we'll see that a person has eye movement, and it's maybe one of their earliest responses. And so we're able to use that movement in an eye gaze response to communicate their needs, or eye linking, or a partner-dependent strategy.
When you're doing the eye tracking or the eye gaze, how much time do you spend reminding staff of the system, and what are some of the barriers that they face?
Actually, you work quite closely with staff in developing the system. Mm-hmm. Usually you want it to be simple, so a lot of individuals could pick it up. New agency staff, float staff that are coming in, has to be a really simple, easy to use, concrete type of a system. Some of the barriers are the change of staff, the new people that you'll be working with. Education is probably one of the largest roles you play early in intervention. So once you find a really easy, consistent method of communication, then making sure all of the caregivers are trained, the family's trained, that there's information about it on the wall that's just as easy as possible for an individual to use.
And maybe you could talk a little bit about sort of the medical course of these people. I guess I don't mean medical. I mean, where are they receiving care? Because that also seems to fit into this a little bit.
A lot of these individuals you'll find are early in recovery in acute rehab environment, and so they're in acute hospital environment, and so it's primarily medical and medical staff that are around them. They may transition briefly into an acute rehab environment where they might get daily rehab if they're making recovery. In some cases as well, these individuals will go from an acute care setting and briefly in rehab, but then quickly into a long-term skilled nursing facility.
And so that also means they've changed environments 2 or 3 times, and so they have new staff that have to be prepared, and especially when they get into long-term care, depending on the respiratory status, they may be in a place where people are very familiar, or they may be in a place where the staff is not that familiar with people who are this severe.
Right. One challenge that I confront a lot is everybody having their own technique, low-tech technique of communicating with the patient. It can be very confusing. So if everybody...
Oh, you mean different staff members?
Yeah.
I see. So they come in and do different things. Okay, I'm getting the picture.
So that can be challenging. So your role is definitely education and having a real presence with the patient and their care and making sure everybody is on the same page. It just results in actually the patient being more accurate in their communication.
One of the things that we talk about sometimes is that a person is accurate in their communication for the first 4 or 5 turns, and then communication turns, and then after that things start to get a little difficult. You want to kind of talk a little more about that, why that may happen and so on?
We've seen that quite a bit in several of the individuals that we've worked with, especially I've seen that a lot in individuals who have had brainstem impairment. They're so fatigued and they have to work so hard to stay alert and awake in order to respond to your questions and use the technique that you're training them to use, that after about 4 or 5 minutes it starts to fall apart because they're really just losing their ability to concentrate and they're just so incredibly fatigued. In these cases, we've really worked hard to first educate the staff as to what's going on so they understand this person can communicate meaningfully, but you need to keep your interactions brief with them. And then that also has led us to alter their rehab schedule. So instead of getting a half-hour of treatment, they might get 10 or 15 minutes at a shot and just get it more frequently throughout the day with more rest breaks.
And I think it really shows up when everyone comes together, family comes together, the staff comes together, the person is there, and they want to have a meeting, decide about the future, and this person has 5 minutes or so of involvement, and these conferences often go longer, and you have to be really careful that the person is communicating what they really want to communicate at a time like that.
Right. Yeah. So then you move on to the formal assessment, some of the key considerations. So when you're doing a formal AAC assessment, funding is a consideration with this population, primarily due to the long-term placement decisions that get made. Since these individuals are so severely impaired, as I mentioned earlier, they might just have a very brief stint in rehabilitation. So they might actually even skip it altogether and go from an acute care hospital to a long-term care setting. This dramatically impacts their access to funding for AAC systems and definitely needs to be considered as early as possible.
Now, I might kind of slip in here and say, and this is particularly true in the United States, where Medicare does not fund this equipment in a long-term care facility, although Medicaid might.
Right.
And, of course, when you look internationally, other countries handle this in a very different way. So, but go on.
Also, technology is another consideration. We're fortunate that technology just continues to advance, and there's a wider range of options available for people with minimal movement. Some of the eye gaze technologies, the head tracking technologies that make a high-tech recommendation definitely possible for this group. And then some other things to consider when you formally assess somebody, the fact that there's really going to be, it's not just a one-time assessment. In this group, it's kind of an ongoing follow-up strategy if you're able to keep in touch with these individuals. If not, then establishing a communication advocate for them is absolutely essential. Because over time, they might change facilities that they live, or their living situations. They might go from a facility to home, or home to a facility, or 2 different facilities. And within the facilities, there's commonly changes with staff turnover, and just making sure that they have an advocate in place so that ongoing education can occur. If there's problems with the technology, it can be troubleshooted. There's someone to go to. That's really an essential part and something you really need to consider when you're doing a formal assessment with this population.
Once you've, that formal assessment's a big process.
Right.
So that takes some time, and it takes the testing and field trial, and so finally you settle on a piece of equipment for someone or a strategy. In most cases, it's a series of strategies, isn't it? In that, you have at times when they're set up in a certain way, they may use their high-tech equipment, but then other times when they're in different situations, they may use low-tech. In fact, they routinely use low-tech as well. So they're what we call multimodal communicators. Anyway, so you've gotten to that stage, and then what's the last phase of intervention?
Well, this phase is the kind of the ongoing assessment piece, where you're really customizing the technology, training the staff, the caregivers, the communication advocates, but also you're preparing for modifications over time and keeping those in mind. In some cases, individuals will increase some of their motor functions, but the recovery is typically very slow. But you want to make sure that the communication advocates and the caregivers realize that if there's a change in motor function, that might prompt an additional assessment. So that might make access to different technologies or more efficient strategies possible for this person. Some individuals also have changes in speech, so some might be recovering some of their natural speech capabilities, and that might change the low-tech strategies that you use with them. And again, just establishing that long-term support system, because there are changes over time, not only in their living situation, but with their own physical state, and making sure that long-term support system knows when additional assessments are triggered or additional treatments are required.
There really are, as I think about it, there really are several different strategies in the long term that people use for speech-generating devices for these individuals. One of them, and the one that was used initially, was switch scanning. This is where the system scans through your options and you activate a switch to make your choice. This was, in an earlier time, this was much more widely used than it is now, partly because we didn't have other options, frankly. And now, while some still use it, it is used much less. It's quite cognitively demanding. The communication rate is quite slow compared to other types of access to AAC technology. And so today we use more head tracking, and we'll be talking about that for those who recover head movement. And then in the last few years, we've become much more active in the area of using eye tracking for these individuals, so that if they have eye control, they can use that to access AAC devices. We'll be talking about head tracking next, and then eye tracking will kind of combine in the ALS part of this talk. And so we've been working on a project for a number of years in order to get very precise head tracking access, so that a person can utilize a laser system that is eye safe, so that we don't have a problem of them pointing it towards staff or a child running up and looking into the laser, that kind of thing. And it has several components. So why don't you kind of introduce people to that, and then we can get on to the videos where we show that in operation.
Well, the Safe Laser Access System consists of a laser pointer that an individual can mount to a headband, their glasses, any moving body part, and then also a laser sensing module. And as David mentioned, this is a safe laser system, and what we mean by eye safety is that the system goes to low power, and so it's a low pulsing beam that's eye safe until it's directed at the laser sensing surface. So that's what makes it eye safe.
And on this slide, they can see the latest prototype of that particular system, and you see the different components of it. And it's also very lightweight and a relatively small footprint, so that it can be used in medical settings, long-term care settings. It can be easily carried with a person if they go to a family kind of activity, or if they leave the facility for some reason or something like that, or go to a different room in the facility. And so, however, I think we'll kind of get into this discussion by talking first about some of the really early prototypes that we developed.
So on your slide, you'll see the picture of our initial prototype that was used, our phase 1 prototype, and it kind of points out where the laser pointer is and the sensing surface. In the first picture, you'll see this gentleman, and his name is Merle. Merle was our first case study with the Safe Laser Access System, and in the early stages of using this, we had 3 areas of exploration, and we looked at it as a primary communication system, also as a head movement training system, and a transitional system, so a system in which you can use to transition into different types of head tracking. As I mentioned, Merle was our primary or early case study. Merle had sustained a brainstem stroke, and when he came to our facility, he was locked in. He had locked-in syndrome. The characteristics of locked-in syndrome is that you're essentially paralyzed, and maybe the only movement that you have is vertical eye movement, and that was indeed what Merle had when he first came to us. We were able to introduce the Safe Laser Access System with him after he'd been with us about 2.5 months. He started to show a little bit of head movement. Prior to that, he used low-tech, primarily, or no-tech, to facilitate as a communication method.
And I remember really clearly when we introduced Merle to this brand new prototype that we had, and his medical condition was pretty fragile yet at this point. So we went in and explained it to him, and said, "Are you interested?" And he flashed his eyes up to the ceiling, which is the way he communicated yes to us. And so we set it up and kind of introduced the staff to it, and introduced his family to it, and so on. And he had it then in his room. And the thing that impressed us is that he was very insistent that when he was in bed, that was turned on. So he had access to it, didn't he? And
Right.
In the evenings when he had downtime, he wasn't in treatment. After his family had left and so on, he would then work with this system. Interestingly enough, when we watched him, we couldn't really see any movement. He was so locked in at that point. Right. And then the breakthrough came.
I think it was really powerful for him to see
Yeah.
that he actually had some control over something, and so that really motivated him to continue to practice that movement. On your next slide, you'll see, again, the picture of him using it in vertical alignment. So one of Merle's earliest head movements was actually vertical. So we had to arrange the messages he was going to communicate vertically on the display. He used those to communicate basic needs to staff, but then he also used that to practice his head movement training.
So in other words, he didn't have horizontal side-to-side head movement.
No.
He was just up and down in the beginning. Okay.
Just vertical head movement initially. After extensive practice on Merle's part, he was able to move over into an alphabet overlay. So he started to gain some horizontal head movement. As you'll see in the next slide, there's a picture of Merle using this display, and he used it primarily as a low-tech method. So the communication partner would call out each letter as he landed on it, and he would spell out his messages that way. He participated in care plan meetings that way. He had conversations with his wife. He communicated and directed his cares with that method.
We have a video of him, and that video will illustrate his use of the system during those early phases. And it also kind of shows the increasing but somewhat motor instability, which of course later on, as he continued to practice and develop, that really stabilized. So why don't we take a look at the video?
If you were having a headache, pain in your head, where would you put the pointer?
Once Merle began to gain some control over his head movement, he started using the Safe Laser System to point to messages he wished to communicate.
What if you were having a pain in your stomach or chest area, somewhere kind of in your torso? Good.
Wow, you were right on.
Yeah. Try to hold it here for the count of 5.
He used the Safe Laser throughout the day to practice head control as well as to communicate.
1, 2, 3, 4, 5. That's good. Good. Okay. Let's go up here to the one at the very top. I feel pain. Hold it for 5 seconds. 1, 2, 3, 4, 5. That's hard to do, isn't it? Hard to hold it still. It's hard to leave it on one, isn't it? It's kind of bouncing back and forth. Can you get the dot closer to the words? And then try to hold it within this area for like maybe the count of 3. Very good. There you go. Nice job. And then you can relax. Okay. Tell me, what did Karen, I know Karen's been having you do food trials. What did you and Karen try yesterday for food?
As Merle's head control increased, he quickly progressed to spelling out all of his messages using the safe laser.
N. O. T. T? No. Okay. New word. Okay, so not. T. O. New word. So not 2. M. U. C. H.
So in the video, you saw him using the first prototype, and in this particular slide, you see the latest prototype that is nearing field testing right now. And this picture here shows him using the device in a somewhat different way. And you were there. I see you standing next to him. Why don't you talk about how he's using it now?
Yeah, Merle used this device connected to a laptop computer. So he would spell out his messages on the board, and the actual keystrokes would be sent to a text document on the laptop computer. He was in a skilled nursing environment at this point. So this allowed him to spell out longer messages without the care staff having to stand there and look over his shoulder as he was communicating.
So now he really has 2 systems, doesn't he? He has the low-tech kind of version where he can point to the letter and the care staff can call out the letter he's pointing to and co-construct the message that he's working on. And then he also has the ability to prepare longer messages that can be spoken through the computer. And since he doesn't travel a great deal, the idea of having the one device act as an access to a laptop computer seemed to be a pretty good solution for him, didn't it?
Yes.
Yeah. We followed up on this. We, as a result of Merle's experience and our experience with a couple of others, we began to realize that there were people out there that might be able to develop in greater head control if they were given a very precise tracking system like the safe laser system. And so what we did is started a study. We had collaborators from quite a number of sites across the United States. And in the end, we settled on 7 people. And these were people who had brainstem stroke, had very minimal movement, or were locked in. They ranged in age from 30 to 66 years. And they ranged in time post-onset of their stroke from 4 weeks. And one man who had the stroke in his late teens or early 20s, I believe, had actually been locked in, or essentially locked in for 18 years. 1 lived at home, 6 lived in a long-term care facility. And so what we did is we evaluated him. And again, once again, you were kind of the lead on this project, so why don't you go from here?
So what we did is we constructed a series of interface displays, kind of targeting the head movement training piece, and they consisted of cells of 2. So we had 2 locations on an overlay, then we had 4, 8, and 32.
So some people started at 2,
right.
And then they went to greater
Right.
as they could handle it. Okay.
Right, exactly. So the idea is they would be assessed initially by the therapist working with them as to what overlay they could handle, and they would work and then progressively work their way up to hopefully 32 cells. So we collected data on the following. We looked at their range and their accuracy across the different interfaces, their consistency of laser movement, also estimates of their laser use for communication. So some of the individuals used it to support their communication. And also we monitored sort of their health status throughout the evaluation report. As we mentioned earlier, this is a population that's typically medically unstable and frequent hospitalizations occur. That's a common occurrence for these individuals. So it was important to kind of gather that information as it might explain some of the results that we were able to get. So this next slide sort of summarizes the results of the study from the 7 individuals. You see that we have at the top there their pre-laser AEC strategy. So what did these individuals use to support their communication primarily before they started using the safe laser? And as you see, all of them used no technology to support their communication. It was primarily eye gaze. Some of it was eye movement to communicate yes and no. Some of it was eye movement and partner-dependent scanning, facial expressions. Those were their primary communication modes. The length of training for these individuals occurred from 1 month to up to 6 months. And then you can see what their movement outcomes were. Looks like everybody pretty much started out with 2 cells. So these are individuals that were really pretty severely impaired and that they had pretty limited movement ability. Some of them were able to increase their movements to control a 32-cell display. A couple individuals transitioned from using the system to using commercially available technology at the time, a head mouse and a Dynavox. You can see there was a number of individuals as well who had numerous medical setbacks and were hospitalized numerous times, which, as I mentioned earlier, is just a common occurrence with this population.
And what we found with that was that if they did have, and it was mostly pneumonia, as I recall, when they did have pneumonia and they were hospitalized, they'd come back so fatigued that it would take us sometimes weeks, sometimes to get back to where they were. And so the health of these individuals really determines. And I think from an everyday clinical perspective, that means that when things are going well, they may be able to use one kind of an option, but you have to have some fallback positions in case the health problems occur. And of course, the other is you have to have a communication system that will support them when they're in the middle of a health crisis so that they can communicate with their caregivers and their health caregivers when they are hospitalized or when they're in their long-term care facility.
Right.
So. We were, I think, really encouraged with these results. You have to remember that these were individuals who were only eye tracking, eye gazing, and eye linking when they started. And there was a subset of them, when the circumstances were right, who were able to move toward a head tracking strategy. And at a deeper level, it intrigued us and them that even though they had been limited for a period of time, that when they were given the appropriate feedback, very precise feedback about the minimal movements they were making, a number of them really increased their ability to move. And that's something to think about, and it's something that encouraged the funding for the next phase. And what we had done also is we realized that with these individuals with very minimal movement, some of the commercially available equipment at the time was what we called relative head tracking equipment, where people had to do quite a bit of head movement to calibrate it and to recalibrate it, and it required quite a bit of head movement to, in fact, interface with the access system. And so we began to work on a second project in head tracking that was really based on what we call absolute head tracking, a 2-camera system for head tracking that we've called the Accupoint system. And so why don't you go on, and you did a lot of field testing on this.
Well, I'll talk about our preliminary case study with the absolute head tracking, or the Accupoint system. The individual I'm going to introduce to you is John. He is a 60-year-old male who has what you would call chronic Guillan Barre. So he initially came to our facility with Guillan Barre. Over time, he was able to recover some head movement, but that's essentially where it left him. He is not able to move below his neck, so his condition is a bit more chronic.
Now, many people with Guillan Barre have a complete recovery, don't they? In fact, 3/4 do.
Right, but there's a subset that have these chronic long-term conditions,
Right.
and that's a situation that John was in. At about 4 months post-onset, he started to regain a little bit of head movement. Initially, he presented as locked in, and he had actually horizontal eye movement. Was his first movement capabilities. But after about 4 months, he was able to move his head a little bit. He started to use a light touch switch with a communication device that was very slow and very frustrating for him. At about 6 months post-onset, we noticed he was able to tolerate longer activities, so he wasn't quite as fatigued, and his head movement was such that we could begin to trial some head tracking technologies. There were quite a few challenges, though, that we had to address with John. First off, even though he had some head movement, it was still pretty minimal, and it was so minimal that he couldn't use a lot of the head trackers, the relative head trackers that were available. And he also was in a variety of positions throughout the day. Because he was so medically fragile, he was laying down in bed quite a bit. He had to be turned to his side for pressure relief. He was in a chair but would have to be tilted back in his wheelchair. So we had to have some sort of access method that could accommodate all these various positions. And it also needed to be a relatively simple setup. He was in a skilled nursing environment by the time we were looking at this technology. Lots of different staff, providers, and so the simpler the technology, the more likely it would be used in this setting. At that time, we had the Accupoint prototype, the initial prototype available, and we thought John would be a great potential candidate for it. And to describe this prototype system, it's a 2-camera, infrared camera system, and it utilizes 3 reflective dots that the individual places on the forehead. And it also just used a conventional computer monitor and a conventional computer with software that would compute your head location and align it with the computer cursor.
And I think one of the really unique situations was in the calibration, and that is that the system is calibrated by looking at a bullseye in the middle of the screen, and all you have to do is get yourself in what you think will be a comfortable position for the center of the screen and sit there.
Right.
And
so
then,
whatever your center is, the computer calibrates that as center.
And then what you do is you move, once that's kind of, you get a signal, then you just move down to a button below it, and that says, I accept this calibration. I think the thing that was interesting with John, getting back to your multiple settings and situations he was in, is that he could be laying in bed, and he could look at it, and he could calibrate it. Then they'd move the head of his bed up a little bit, and he'd just look at it, recalibrate it. He'd go on his side, he'd look at it, recalibrate it, so that and it didn't require moving across the whole interface like many of them do to recalibrate. And I think for John, that was a really important feature of this.
Right. And also another interesting feature of this system is that it could be scaled up or down based on the individual's movement capabilities.
So sensitivity changes.
Right.
So little movement.
Right.
Lots of movement. Okay.
So to give you an example, in John's case, because he had minimal head movement, we changed the scaling to 10-to-1. So a little bit of movement would allow him to move the cursor completely across the screen.
And I could never use 10-to-1
because
I couldn't be that stable. All right.
Right. And to just give you an idea of how minimal his movement was, when we measured it from the tip of his nose, his head excursion, it was 1/4 inch left and right and 1/8 of an inch up or down. So that's really minimal movement. Almost, probably if you were to look at him, you would say this guy's probably not moving his head. But it was enough with the scaling settings that he was able then to completely control the computer cursor.
I think one of the other issues that relates to this, especially in the calibration, is that when you're in a care facility and you have multiple staff, many of them not necessarily computer savvy, some of them are, but the idea that the calibration is essentially independent, that he can do it. really helps out because it means you don't have to bring staff in to help you recalibrate. Even when they're helping you maybe change your position, you can take care of all of the rest of it with the computer.
Right.
And I think staff really appreciates that.
They do, yeah, definitely. Some of the results, the positioning, we found that John was successful regardless of whether he was in his wheelchair, bed, laying down, on his side. And we also examined what communication functions were served by using the system. And he used it for written communication throughout the day when he was able to tolerate his talking valve with his vent, his one-way valve. And he also used it extensively to email and get on the internet. But at night, he used it to support face-to-face communication. He wasn't able to tolerate his valve overnight. So evening and nighttime, when he had pretty extensive cares and communication with nursing staff, he was able to use the Accupoint system to facilitate that communication in those situations.
And this is one of the other shifts that we're beginning to see, and that is that people are using this equipment for more than just face-to-face.
Right.
As you mentioned, on the internet, email, even supporting some of his medical care with it, communicating with people who are some of his providers through email and that kind of thing. So we're really beginning to see a shift in the use patterns of AAC.
As Dave alluded to earlier, the setup and training for staff was surprising for us, a surprising result in that, in John's case, we had one intense training session with the patient and staff present on how to set it up, and beyond that point, John was able to train all other staff. It was simple enough, and he primarily controlled it, that he could tell them to open up an icon, hit a button, and he was good to go.
Mm-hmm.
Duration of use also, he used it quite a bit. Email, internet was approximately 2 hours a day. Face-to-face communication was 8 to 10 hours in the evening and overnight. So an extensive period of time each day using the Accupoint system.
And how long has he used it now?
John has used it probably about at least 3 years, 3 or 4 years now.
Yeah.
We have a video of John that kind of illustrates his use of the Accupoint system that you can view at this time. Why don't you show how you communicate? Yes, Merle. Yep. So real clear, looking up, and you kind of hold it there to make sure people know that. Right, and down is no.
Merle is a gentleman who sustained a brainstem stroke with locked-in syndrome. Initially, he was only able to communicate by eye movement. He moved his eyes up for yes and down for no.
Okay, so we have D so far for your wife's name. And I can tell real clearly that you're looking at row 3. Okay.
He was able to spell messages by using an eye linking technique.
You're looking at row 1 and the letter O. Good. So you're looking at row 2, Merle?
Okay, in the video you've seen John use the Accupoint. He's very accurate with it and effective with it. In fact, we have him participate in the development or in changes of that technology. And he also uses some of the other related developments that we have. The AccuClick for controlling other software, managing the mouse functions and so on for other software. And then AccuKeys, which allows him to spell and to interface with other software. And so he's been a very active participant. Next, we're going to be going on to eye tracking technology, and we're going to discuss this in light of people that we serve with ALS. And you see our colleagues listed there, Laura Ball, Amy Nordness, and then the two of us. And our strategy is that, research strategy through the years is that we follow a large number of people with ALS, amyotrophic lateral sclerosis, or Lou Gehrig's disease. And it's a degenerative disease, as you probably know, and we follow them from diagnosis, frankly, until death at about 3-month intervals. And during that time, we collect a number of, several pieces, a large number of pieces of information that helps us make clinical decisions. Once again, I refer you to the Green Book, Augmentative Communication Strategies for Adults with Acquired or Acute and Chronic Medical Conditions. And there's an entire chapter on there that lays out the phases of intervention that we'll be talking about today. We'd like to introduce you to Olinda. Actually, she's been someone that you've worked with, so why don't you know her well. Why don't you introduce her?
Well, Olinda, she's a 60-year-old woman. She resides at a skilled nursing facility here. She's had ALS for a number of years. One of her very early first systems was a scanning AAC system. About the time that I saw her, she had just received a new eye tracking AAC system, and she had gone a number of years without the ability to access a computer system just due to her difficulty in being able to access a scanning device with a switch. And she's currently has been using her eye tracking system for about 2 years.
And how long has she been unable to speak?
Quite a number of years, at least over 5, maybe almost up to 10 years.
Okay, so she obviously is someone who had spinal ALS to begin with. That was her presenting symptoms, and then in time it reached up into her brainstem and affected her speech, and that's why she probably has lived as long as she has with ALS. And we have a video of Olinda that we're going to show. We're going to change it a little bit. We're going to show you the video first so you get a little feeling of what it's like to see someone who uses eye gaze to communicate. So why don't we go ahead and roll that video now.
And I'm sure there'll be another 10 things to come up for.
This is an eye gaze computer. I use it to communicate with family and friends. I also use it to read books and my Bible.
And so there you've turned on your call light, right? Mm-hmm.
I love the eye gaze. It allows me to keep in contact with my children.
As you can see from this video, she uses eye gaze, uses it accurately, uses it effectively, and she uses it to support what communication functions?
She does use it to support some face-to-face communication with her staff, but she's primarily using it to support communication, written communication, care providers and family at a distance via email.
Okay.
She uses it extensively, and in fact, when she is having some difficulties with her system, I get an email from her, and she also supports medical needs that she might have with it. So it's been a real efficient method for her and really opened up a lot of opportunities that she didn't have before.
So she lives in a long-term care facility, and then she manages her medical, she manages you,
Right.
she connects with her family.
Right.
And this is a pattern, we'll show some data that we did on follow-up, and what you see is that this is the pattern we're seeing, that communication has become more than face-to-face. Let's talk a little bit about AAC decision-making in ALS. And the chapter in the Green Book here was written by Laura Ball, myself, and then Lisa Bardak. And in phase one, there are really three distinct phases that we think about here. In phase one, the people are generally just have learned that they are diagnosed with ALS. They are still speaking. And yet our task is to help them monitor their speech performance and to do what we need to do to help make their natural speech effective for the time that they can still speak. And, of course, we need to work with them to educate them and the key decision makers in their families about the timing of making decisions about communication as well as other areas of their lives, obviously. And so what we do here is we worry about, energy conservation. In other words, if you're going to go to a big party tonight, why don't you take it a little easy for the rest of the day in terms of your talking. The other is we kind of teach them how to manage environmental issues so that their speech is more effective. I remember a woman who really would go to church. Her religious family was really important to her, but had a great deal of trouble talking out in the area where everybody else was talking before or after services. And so she managed to reserve a bit of a room off to the side where she would kind of go in there, and then people would come and visit her in a quiet place. We use voice amplification for some people, and just a portable voice amplifier. You mount the mic beside their mouth, maybe put the speaker in their pocket, and that helps manage groups or manage communication in a noisy situation. And then we go on and we monitor very regularly their speaking rate. We find that speaking rate is simple to measure, and it also is a very effective predictor of when they're going to experience decreases in intelligibility, speech intelligibility, that is going to make their communication with others difficult. This is a bit of a complicated slide here, but what we have on the vertical on the left side is their percentage of speech intelligibility represented, and then on the bottom we have a speaking rate. We used the sentence intelligibility from the speech intelligibility software, and the reference will be provided for that later on, to measure speaking rate. And what we find there is that the average speaking rate on that task for a typical adult speaker when you're reading those sentences is about 190 to 200 words a minute. And so what we do is we simply, when they come in for their visit, their medical visit at the ALS clinic, we have them read those items, and then what happens is we can measure the speaking rate right as they're doing it, so we can say, okay, today your speaking rate was 180, things look good. I think that you're going to be doing fine for a while. And then the next time they come in, or a time or two later, we may measure it and say, you're down to 160 now, yet you're still doing well, although we're beginning to see. And what we're doing is we're getting them ready to make some decisions. A lot of times we make medical decisions after we have severe symptoms. We have the fever and then we go to the doctor. This is common for all of us. And in these people, they have to make the decision well in advance of losing their speech intelligibility. So they have enough time to learn, complete an assessment, do a trial, and then receive the equipment, have it purchased, and then finally learn how to operate it. So now getting back to this slide. What you'll see is that when people are speaking on the right-hand side of the graph at about 190 to 200 words a minute, their speech intelligibility is over 90%. And then as they slow down to 180, 160, 150, their speaking rate stays at over 90%. And then once they get it in the neighborhood of about 130 words a minute, we see the first people kind of start to fall below the 90% intelligibility. And so once they get past 120 words a minute, then we start to see a number of people falling out. So what we do is we kind of have a rule of thumb that when people, we tell people, when you get down to 125 or 120 words per minute, we're going to recommend an AAC assessment. And we find that prepares them for it, and if they have questions along the way, we introduce them to equipment if they ask that. If they don't, we say when that time comes, we come. And we find that that way of preparing them is quite effective. Speaking rate can be measured over the phone when you live in the northern part of the country where you have winter storms, and when you have ALS and travel is difficult and you can't make a clinic. We can have them read the sentences to us over the phone, and we can measure the speaking rate. And so we can monitor it and say, okay, when you are feeling better or when the weather is better, you need to come in and have an assessment. Okay. This is another bit of a complicated slide, but it contains an important kind of message, and that is that on the previous slide, you saw the red dot squares were for spinal ALS. The blue were for bulbar or brainstem ALS, and then the black were for those that were mixed in symptoms. And what we see here is what's quite typical, and that is on the vertical you have intelligibility of speech, and on the horizontal, on the bottom there, you have months post-diagnosis. And what we see is that the people with bulbar ALS or brainstem ALS lose their ability to produce intelligible speech much earlier in the course of the disease than the people in red, who are the people with spinal ALS. And so we see that the bulbar individuals are showing a decrease in intelligibility within the first year or even earlier than that, where you see the spinal people will go on for quite a number of months, maybe up to 2 years or past that, before we see them intelligibility. And so what we find, however, is that speaking rate, going back to that particular slide, speaking rate is a good predictor no matter what, and that's really effective. So that's how we make that decision. And that ends phase one. So during phase one, we help them maintain optimal natural speech. We don't do speech intervention in the typical way because we tend not to give them exercises or things like that for speech, just like the rest of their body. And so that isn't recommended. Rather, we prepare them. And in phase two, it's a formal assessment. Now, you do a lot of these formal assessments for our group. Right. You want to talk a little bit about what a formal assessment looks like?
Yeah, a formal assessment, and usually they come to you, an individual with ALS will come to you prepared for what they're going to see in terms of the formal assessment. Occasionally, if they're a late referral and that whoever they were working with wasn't aware of kind of the rate guidelines, they come to you a little late in the game, it's a bit surprising. But they come to you prepared, and you start showing them some different kinds of technologies. And typically the assessments that I do, we work with trialing a variety of different technologies and really understanding the individual's communication needs and what types of communication we need to be able to support with the technology that we're going to have them trial.
Now, obviously physical issues are important, and yet there are some other issues that figure into this, don't there? For example, what about cognitive? Is cognitive an issue with these people, or is it all motor?
Well, there are a subset of individuals that do have what's called a frontotemporal dementia, and sometimes those individuals can be difficult to point out early. Sometimes we see it first starting to manifest itself in terms of their decision making. So sometimes this is a subset of individuals who delay making some of the really crucial decisions, such as whether they're going to do ventilation, the feeding tube, and sometimes other things, such as whether they want to have a wheelchair assessment. Things just really seem to be delayed. They also are somewhat, almost seem kind of apathetic to what's going on around them and their declining condition, and don't seem to be able to make a decision one way or the other in terms of the type of technology or route they want to go to support their communication.
You mentioned a couple other things. You mentioned feeding tubes, and that's kind of a different discussion. Probably makes what I've seen it do is you get a feeding tube, and it makes feeding much easier and much less risky and much faster. Right. And so a good friend of mine, Tom, had ALS, and the feeding tube allowed him to, receive his nutrition very quickly so he could then go out with the rest of us to a ball game, where if he would have had to spend an hour and a half eating every meal, that would have been a very busy, or taken up a lot of his time. Interestingly enough, it had an effect on communication, because if he went out to the ball game, he would have to talk to people. Right. And so we found that while it didn't necessarily extend his life, it made it a lot easier, and he communicated more. Right. What about ventilation?
Ventilation is something that at first assessment I usually talk to individuals about and see what kind of decisions they've made with regards to that.
And maybe we should point out right away that there are kind of two kinds of ventilation here. There's the kind of ventilation, the CPAP type ventilation, where they may maybe wear a mask like this that delivers concentrated oxygen to them. And that's pretty common, isn't it?
And that's often in the overnight.
And that's often in the overnight, and then maybe in time during the day. And probably, while it makes their life easier and so on, it isn't the big life extender that invasive ventilation.
Right.
So what's invasive ventilation?
So invasive ventilation, these individuals typically have a trach, and they're actually connected to a ventilator, and that supplies the breath for them, so they can live for an extended period of time on a ventilator. Some individuals that I've worked with here have lived up to 15 years potentially with the ventilator. It's important to know this, what decision they've made right up front, because it does influence the kinds of technology that you look at. Mm-hmm. Individuals who choose to go the route of the invasive ventilation might live to a point to where they're essentially locked in into their bodies. Mm-hmm. So you want to make sure that the technologies that you're looking at are adaptable to accommodate the person's declining physical condition over time.
Okay. And, once again, I'd point out 15 years, yes, we do have that happen, but we do also see it, even an extension of 2 years, 4 years, 5 years, 7 years is really important. Going on with the formal assessment, another part of the formal assessment while we're making decisions about the high-tech AAC device, once again, these are multimodal communicators, and so they will need low-tech options for times when they're in bed, if their system isn't set up for bed, when they're in the restroom, these kinds of things. So once again, part of the formal assessment is to provide them with a range of communication options to meet their needs that is acceptable and valuable to their family members and caregivers. And then the third phase is to finalize AAC assessments, to do equipment trials, prepare paperwork, make funding requests, get the prescriptions that are necessary depending on your funding requirement, if it's a Medicare, Medicaid, insurance funding requirement, and so on. And then finalize the AAC options that are used, the range of AAC options that are kind of switching now a little bit. What we did is we followed the first 15 people that our group had done with eye tracking. Once again, this is there are a variety of eye tracking systems out there. We acknowledge that. This is only with the one, which was the Erica system from iResponse, and it was their first generation in the sense that it was the single camera system, and now most of the companies have the dual camera system. And so we'd like to be sure that people are aware of the time in which this occurred. The eye gaze was, at this time, eye gaze was just beginning to be regularly used in ALS because the new technology was there. And we were impressed with the possibilities that it had for some of these people with limited or movement or essentially no movement, or people who were losing movement. And we wanted to be careful about it. We're not going to spend a lot of time talking about this, but the eye gaze tracks the eye movement by monitoring the reflection in the eye, and using cameras then to convert this information, and computers to convert this information to mouse tracking. And then choices are made using dwell, meaning if the mouse cursor stays on a location for a set period of time, which can be adjusted, then it will accept that letter or that word or that phrase or whatever. If you look at the literature and the presentations on eye tracking, there are a variety of concerns that were initially presented. One of them was physical ability, head movement, ventilators, dry eyes, and so on. And so those were issues that were of concern. Another one was the environment, the lighting in the environment, the home, the nursing facility, wherever the individual was, being outside, and so on. Another issue that was put forward was positioning. In other words, were you always at a table when you communicated? Could you communicate in a table and in bed? All these kinds of things. Another issue were glasses, the reflection that came from glasses, or contact lens, or all these issues were there. And then, of course, the general lighting in the area. So there were a group of issues that we wanted to pursue to try to understand with these 15 people. We selected 15 people who chose eye tracking after their assessment. And so, in other words, they made the decision that they wanted to go with eye tracking, and we then asked them if they would be willing to participate in this follow-along study of ours. These were 15 consecutive people who had selected eye tracking. So we weren't going and picking different people at different times for different facilities. Rather, these were 15 consecutive individuals. You see there on the slide, 10 men, 5 women. The age, 52 years, although it went from 39 to 71 years, so we had quite an age range in that bunch. 40% of them were on invasive ventilation, and so following up on our previous discussion there. And so we found that there were people with 2 different kinds of muscle capability or strength capability. 53% of them having a significant spastic component to their movement patterns, and 47% were flaccid or quite weak. They each received instruction until they could operate the device to communicate. And once they received it, they received troubleshooting support as necessary. You did some of this. What was the nature of that? Just they would contact you and say, we're having a little trouble? And
And it typically resulted in lighting types of issues that we had to troubleshoot that were interfering with the calibration or the effective use of the system. In some cases, it was an individual who wore glasses, and we kept getting glare on the glasses and just doing those kinds of adjustments. And those were sort of the kind of the environmental and the positioning and the lighting were the typical troubleshooting sessions.
And the research strategy was really a survey strategy in which we interviewed the people who used the technology, family members, whoever was there and could give us insight about it. At the result of this, 14 of them became successful eye gaze users. One discontinued because they had trouble controlling their eyelids. And this sometimes happens where the weakness that a person experiences means that they have trouble keeping their eyelids open. And this individual, as I recall, the eyelids would kind of droop and they would obscure the eye, and then the tracking would be interrupted. And it just got to be a little bit too much of a hassle, so they discontinued use. we were able to, for those 14 that were successful, we were able to manage different lighting conditions. Excuse me here just a second. 10 of them used dimmed lights to some extent, and 4 of them switched to fluorescent bulbs at home. That worked better with them than the typical floor lamp in the background that seemed to get in the way. I remember one person would call you and you would say, "Why don't you move the floor lamp over the phone?" And that often solved the problem. And then 3 only used overhead lightings and got rid of the floor lamps that were at eye level around the room. However, 53% of these individuals were wearing prescription glasses. 3 of them had reflective type lenses, and with work, we were able to work around those, wouldn't you say?
Mm-hmm.
I mean,
yeah.
I don't think there was anyone that we said, no, you can't. Well, 14 out of the 15 were successful, and the one who wasn't was a different reason.
Yeah,
so.
right.
Yeah. It was kind of interesting when we went to them and said, why did you choose this technology over other kinds of technology? And 58% of them said I didn't have much choice because I only had eye gaze movement available to me, so that's why I did that. 27%, or a full quarter of them, said, I want to be set up so that if in fact I deteriorate further, which you expect to do, and if in fact I decide maybe to go on ventilation, I've got a system that I can manage. And so they were wanting the flexibility, the multiple access options. 13% chose it because they were unable to scan. They just couldn't learn how to scan efficiently. And so they did. And then 7 just said, this is what I want, and didn't provide much more of an explanation. There you see a little bit of the funding pattern that was available for these individuals. This, I think, is quite interesting. The question always comes up, how much instruction do we need to do? And what we found, across all people, it was about an average of 5.5 hours. But it ranged from 2 hours. In fact, most of them, the largest group, 5 of them, managed it with 2 hours of instruction. And then the next group, 3 hours of instruction. And really, the one that really raised these numbers was the person who had 20 hours of instruction. And that was a unique individual. And you were involved with that person.
It was the individual with iapraxia.
Yeah, we called it iapraxia. And the symptom of it was that when we evaluated the person, they were able to pretty accurately point their eyes to things. When we pointed to the A, they would look at the A and all that. But when they started to communicate, what happened?
They were unable to spell. We were troubled by that. So they would be maybe stuck in a pattern near a couple letters, going back and forth between letters. And as we would start to cue them more, then they could get to the right letter. And through low-tech means, we saw that they could spell, the individual could, but it seemed like when we had them generate communication themselves using spelling and eye gaze, that's where the breakdown was occurring.
So the problem wasn't in spelling.
Right.
The problem was when they had a message and they tried to do the motor planning necessary to communicate that message, that things kind of fell apart.
Yeah.
And so we did have the opportunity to put them in an ongoing instructional program, and it resolved. But it took quite a number of hours of instruction.
And early on, this individual, we relied a bit more on full messages.
Right.
So this individual could still support their communication while they're continuing to work through the problems they were having with the iapraxia and spelling. So
anyway, actually, I was surprised at this group that they didn't require more instruction than what they did, actually. We see it on this next slide. You see troubleshooting issues. I think we've kind of alluded to that already, so I won't spend more time on that right now. One thing we really wanted to talk about was use patterns. What it does is it really reveals, I think, a changing pattern in how people communicate when they have complex communication needs and when they are required to meet these needs with AAC. What you find there is that well over 90% used it for face-to-face, and there was one who was kind of using it yet for the internet kind of email and so on, but was still speaking to some extent face-to-face. And then you see there that 40% were actually using it to speak in groups. This was quite encouraging. But the electronic communication, the phone, the email, and the internet, what you see there is, over 70% of the people on email, over 80% of the people on the internet. And so what we see is that people were really, in significant numbers, given the age span that we were dealing with, said, no, this is an important way for me to communicate. And many of them communicated regularly with family at a distance, getting the benefits of the internet because, my daughter or granddaughter can type very quickly and get messages to me, and then I can return the message even though it does take me 2 or 3 or 4 times as long as it does them. And so we certainly saw that emerging. We'd like to just close this webcast out with a few acknowledgments. Once again, Merle, John, and Olinda just played such an important ongoing role in our program. They are real AAC experts for us, and we appreciate them. And then we have colleagues in a variety of different settings that you see listed there who operate ALS clinics and who collaborate with us on the ongoing data collection that we have. We also have a group of references on the next slides that refer to the content that we have presented. And so thank you for watching.